Corneal blindness is one of the leading causes of monocular visual loss, and around 200 million people get corneal ulcer in India alone. And unfortunately, fungal keratitis carries a worse outcome than bacterial keratitis. Why we hate fungal keratitis? What are the challenges? What are the difficulties? Why, when we receive a call from the ER saying, we might have a patient with fungal keratitis, we become a bit anxious and worried. First of all, it's not easy to make the diagnosis of fungal keratitis, and it's not easy to get a confirmatory report that will support your clinical diagnosis. In one animal study, they had 10 animals with fungal keratitis, and they did culture and scraping. Only 3 out of 10 had positive result. طبعا things are better now with the PCR, but not all of us will have access to PCR. The other problem in an antifungal agents is not as effective like antibiotics. We don't have a lot of options like we do with bacterial keratitis. The antifungal medication is toxic to the human body. The antifungal agents are bulky and large, and it's not easy to penetrate the ocular tissue. And once you started the antifungal agent, you have to be committed. It's not like conjunctivitis where you will give the antibiotic for 7 days or so. Usually, fungal keratitis deserve a very long and intense therapy. That's why, personally, I don't like to start antifungal agent unless I have evidence that I'm dealing with fungal keratitis. This is the perfect scenario. Sometimes there is an exception, of course. The other thing is difficult to eradicate the fungi and the hyphae from the ocular tissue, especially if you have large fungal keratitis or large infiltrate. Sometimes it's difficult to eradicate all the organism by doing therapeutic keratoplasty. All of this add to the difficulty in managing fungal keratitis. Fungi are eukaryotic, which means that they have their own nuclei. They feed an organism, either living tissue or dead tissue. The fungus need to have access to the cornea. So you need to have an epithelial defect so the fungus can invade the corneal stroma, where it will start to replicate, will start to produce enzymes, toxin that will cause inflammation and tissue necrosis. Sometimes fungi can invade an intact descendant membrane, and sometimes it can cause even endophthalmitis from corneal infection. Usually we divide fungi to either, as you all know, to yeast like Candida, or filaments, which is septated or non-septated. Non-septated like mucor, septated either non-pigmented or pigmented. Non-pigmented like Fusarium, which is the most common cause for fungal keratitis worldwide. The major risk factor for fungal keratitis is trauma. In one study of fungal keratitis, they identify trauma as a major risk factor, where around 44% of all fungal keratitis were caused by or initiated by trauma, especially in people who's working in agriculture, like lawn mower, اللي يقطعون الزرع, they're at risk for fungal keratitis. يعني يقطع انجرحت عينه, piece of plant, حكها, boom, he developed fungal keratitis. Other risk factors, steroid, other medication like moxifloxacin has been reported to have contamination, fungal within the bottle, jeopardizing the ocular surface, like patient who had PK or other corneal surgery, and sick cornea, like patient with chronic keratitis, either shield ulcer or chronic herpetic keratitis or a neurotrophic cornea, at risk for fungal keratitis. In 2005, there was an epidemic of fungal keratitis caused by contact lens solution from Bausch& and Lomb, Reno, and the story started in November 2005 when Hong Kong healthcare officials noticed increased number of fungal keratitis, to be specific, Fusarium keratitis, and it's been linked to Reno, which is the contact lens solution. They contacted Bausch& and Lomb company, but no action was taken, unfortunately. Then in March 3rd, Dr. David Chu in New Jersey, he called the Bausch & Lomb office when he noticed that 3 of his patients developed Fusarium keratitis, and all were using Reno contact lens solution. Then in March 8th, he contacted the CDC, the Controlled Disease Center. And in April 10th, 2006, the CDC announced that they are investigating around 100 patients of fungal keratitis. And in the next day, April 11th, Bausch & Lomb announced that they're gonna stop selling Reno contact lens solution. And that day, around 15% of the company's stock price dropped. And then in May, they withdraw all the Reno contact lens solution from the market. So fungus is part of the normal flora. Each one of us has a fungi in his eye. The number of fungi will increase if you have a sick ocular surface. Fortunately, only 6 to 20% of all microbial keratitis will be caused by fungal keratitis, especially, as we said, in the rural area where agriculture is more common than the city itself. Filament is the most common cause for fungal keratitis worldwide. However, in the North Hemisphere and in cold weather, Candida is more common than filaments, where Fusarium likes moist and hot weather, Candida likes dry and cold weather. طيب, who wants to take this photo? وش اسمك؟ أي level مرام R4 line. We want someone junior. Anyone junior in the room? Junior في residency بس. No one? طيب مرام, do you want to explain what do you see? Excellent. So she did very well, huh? Usually when we see a picture or a photo and someone asks us, what do you see? We jump right away to the pathology. She took her time. This is the right eye of the patient, mild blepharitis, injected cornea. Then she described the major findings in the picture. So if I tell you this is a 25 years old male complaining from pain, redness, and blurry vision for the last 2 days. He's a contact lens wearer. How would you approach this patient? Or what is in your mind now? So when you describe this, you say that there is no hypobion, there is multiple lesions. I'm not sure if there is an epithelial defect or not. I want to put fluorescein. How would you approach it? First, what is in your mind and how would you approach it?
Taking shower with it or sleeping with it. Then I will move to analyze other risk factors, if there is any history of trauma, if he's taking any systemic steroids, if he's having any Is it a recurrent history? If he has any history of herpetic eye disease or even skin rashes in the face. Um, does
Excellent.
he has any topical medication and has been treated elsewhere or
Okay. No, this is his first presentation, and he's been dealing with this problem for the last 2 days. Um, uh, so, what is in your mind now? You covered the history and the examination very well. يعني what you are dealing with, and what's your next step?
okay.
يعني is this a typical pseudomonas ulcer that comes with the contact lens wearer?
No. As there is a further emergence, I would suspect fungal infection, as in this case. I would put Canthamoeba and Pseudomonas in the differential diagnosis as well.
Excellent. Common still is common. Huh? Yeah.
I would like to scrape the patients.
Okay. And the scraping you will send for all the organisms that you mentioned. Huh?
Yeah.
Okay. Then you will give him Vigamox, you will give him fortified antibiotics, you will give him voriconazole, you will give the patient chlorhexidine. What you will do?
I would give him a fortified antibiotics.
Okay. So you're going to treat it as a bacterial keratitis?
Yes.
Okay.
And I'm going to wait for the culture because fungal infection, we don't treat until the culture is proven.
And any objection? Or everyone is agreed with Maram? Okay. So no much of improvement. By the way, I will do exactly the same thing. Okay. I will do exactly the same thing. Then no much of improvement. And the culture came back negative. The stain negative. The culture so far negative. And the stain is negative. What you would do?
I would add more culture for the atypical bacteria. I will include culture for Acanthamoeba.
No.
Already sent. Yeah. Huh? Already sent.
Why we thought about Acanthamoeba? You have to think about Acanthamoeba in this case because it's multiple, like dendritic-like lesion, contact lens wearer. So you have to do Acanthamoeba culture. Right. You have to. Huh?
From the beginning.
Yeah. Okay.
He's not improving.
So he's not improving. Culture is negative so far.
Can I do the confocal microscopy?
Confocal microscopy? Good idea. Ella, you can utilize it. Huh? Came back equivocal. No much of either confirmatory or negative any infection.
And the culture is bending for fungal,
yes, the culture is negative so far. The stain is negative. So keep your thoughts. Think about it. We'll come back to this case. Sure. Sometimes, as Dr. Maram mentioned nicely, clinical features of fungal keratitis, usually it's a slow progressing infection. It's not purulent like Pseudomonas, for example, although sometimes you can get fungal that is very potent and aggressive. But the usual course of fungal keratitis is very slow progression infection. Multiple lesion, satellite lesion around the main lesion. Sometimes you can get large epithelial defects. Sometimes you can get a linear epithelial defect, but there has to be an epithelial defect to get an access to the corneal stroma. Usually there is no much of discharge. Huh? Yeah, usually with Pseudomonas, you will get a lot of secretion and discharge. With fungal keratitis, there is no much of discharge. Like this patient, barely you can see any pus or any secretions. Okay. Sometimes you can get pigment, and this is specific for curvularia. Curvularia fungal can get some pigmentation in the head of the hyphae. As Dr. Maram mentioned, usually we send for smear and culture. The smear, gram stain, GIMSA stain, GMS, KOH is helpful, although KOH usually used for dermatology. And the main idea of using the potassium hydroxide is to dissolve the keratin that present in the specimen itself rather than to identify the organism. Huh? Culture, separate or brain heart infusion culture is helpful. but nothing can compete the PCR. As I mentioned in one animal study, 3 out of 10 had positive culture, which is very depressing, to be honest. Huh? So back to our patient. What we did, the suspicion. First of all, your job as a physician, that you need to have very high index of suspicion. Huh? If you want to be an excellent doctor, you need to think outside the box. You don't to be an average doctor. Okay, give him fortified antibiotic. Continue fortified antibiotic. Continue. Like what you mentioned, it's atypical infiltrate. There is multiple organism. There is contact lens as a risk factor. So I need to be serious in treating this patient or this infection, and you need to think very quickly, huh? Especially if you are dealing with acanthamoeba or fungal infection, because if the infection goes deep, maybe it's game over. You can, and this is only 25 years old patient, so and this would make someone excellent doctor and someone okay doctor, huh? So the index of suspicion is still high, and I know that I'm dealing with a typical case here. So what we did, once we get the smear negative, we took the contact lens and we sent the contact lens for culture, and it came back as filament. And the culture negative up to 3 weeks. The patient's culture negative. There is no much of organism. It's an early infection, and we know that the sensitivity of the culture is not that high. But we got lucky when we sent the contact lens, and it came back positive for filaments. We treated the patient with voriconazole, and the patient infection resolved, and he has 20/30 vision with correction, with glasses. Huh? So we saved this patient from going down the road. Huh? Why? As you mentioned, you need to have high index of suspicion. There is something atypical here. I'm not dealing with a regular Pseudomonas. So the clinical features are very, very key in diagnosing corneal ulcers. And don't underestimate them. Spend time in examining the patient, checking the corneal sensation, the pressure, what's the pressure, huh? The risk factor, dig deep in the history. And confocal microscopy, if you are lucky, can identify the hyphae. And usually the hyphae will lie parallel to the collagen lamellae. Okay, so treatment of fungal keratitis. As I mentioned earlier, we are not so lucky that we don't have a lot of groups in antifungal like we do with antibiotics. And mainly 2 that we use for corneal infection, the bulines, which is the natamycin, and the amphotericin, 0.15%, which act by binding to the estrol and damaging the cell membrane, and the azole, like voriconazole, which prevent the inostrol convergent to ergostrol, and this will damage the cell membrane. In the early 2000s, there is a lot of articles talking about how good voriconazole is, huh? in penetrating the ocular tissue. Even if you use it systemically, it will go to the ocular tissue. And in some of the in vitro study, the efficacy of voriconazole was 100% against most of the fungi that can cause corneal infection. So this is amazing. Huh? So this is really good news. You can treat fungal infection with a voriconazole, readily available in a tertiary hospital, can be prepared, widely available, and 100% efficacy. Huh? So people start to use voriconazole a lot. Till we got the MUTT study. We don't have a lot of excellent study in cornea, and this is one of them. So I highly recommend that you do read it in details. Not only you will learn a lot, it will open your mind how to do a well-structured study in cornea. So the MUTT study is a collaborative work mainly between the state and India. It's a blinded RCT where they recruited more than 300 patients with fungal keratitis, positive smear fungal keratitis. The vision has to be between 2040 and 2400. And they had two groups. The first group received netamycin, 5%, and the other group received voriconazole, 1%. They received the medication every hour till reepithelialization. Then they received the medication QID for 3 more weeks. The primary outcome was the best corrected vision at 3 months, and the secondary outcome was the vision at 3 weeks, incidence of corneal perforation or the need for therapeutic keratoplasty, eradication of the organism in day 6, so they recultured the patient in day 6, and the scar size. They had to stop the study. Why? Because in the voriconazole group, they had more corneal perforation. And when they analyzed the data, they found that the netamycin group had better vision compared to the voriconazole group, especially in fusarium. It's worth to mention that 40% of the etiology or the suspected organism in this study were fusarium. And this, not only that the corneal perforation was less in the netamycin group, not only that they had better vision in the fusarium group or equal vision in other organisms. When they cultured the patient in day 6, 50% of the netamycin patient had negative culture, compared to 15% only in the voriconazole group. So this is really game changer in management of fungal keratitis. And by the way, netamycin is the only US FDA approved drug to use for fungal keratitis. It's available by Alcon. Not easy to get it because it's not a common disease, but still it is available. So this study, the MUTT study, has really changed the way we manage fungal keratitis regarding the medical management mainly. Then there is another study, or there are actually multiple studies that they showed that voriconazole has lower efficacy compared to netamycin against fungal keratitis. Who wants to take this case? Ibrahim. Yalla, Ibrahim. So let me give you a heads up. So this is a 24 years old female monocular patient. They lost the other eye due to diabetic retinopathy. And what do you see here?
So first of all, this is a slit lamp photo with a slit beam for the left eye, showing mildly congested conch, and there is a central corneal infiltrate with the epithelial defect and hypobion. It seems to be hypobion inferiorly. I think the AC is deep. It's not very clear, but I think it's deep. So there is area of thinning centrally.
Excellent. So not only an epithelial defect, there is thinning centrally, huh? Okay.
I cannot appreciate the lens. I think if there is no view, B scan would be an option to rule out any endophthalmitis if there is endophthalmitis.
What else do you see, Ibrahim?
Neovascularization inferiorly.
So this tells you what?
Chronic infection.
Excellent. So this is a chronic infection. So this patient actually underwent vitrectomy in this eye. Then she developed corneal abrasion or epithelial defect, and her doctor placed a bandage contact lens, as we always do, sometimes to promote healing, and the patient developed infection. And prior to her presentation to us, she'd been treated with fortified antibiotics and voriconazole every hour for 3 weeks. And her condition did not improve, and now she is in your hospital. What is your next step now, Ibrahim?
First, I would stop the voriconazole and I would do re-scraping.
Okay. You will stop voriconazole for how long?
Until I have a proven culture to treat the fungal.
Okay.
I would start.
So you will stop for the voriconazole,
Yes.
and you will re-scrape the
Re-scraping,
patient.
then
When you
I-
will re-scrape the patient?
Immediately I would re-scrape.
Immediately. Anyone agrees with Ibrahim? Anyone agrees? And I do agree with Ibrahim, by the way. Why يعني I said anyone agrees with it? Because sometimes you will read that you have to stop the antibiotics for 24 hours, then re-scrape. And my rationale that if my medication is not working, the patient is getting worse, he's not improving, or she's not improving, يعني stopping the antibiotic will not add any benefit to me. ها؟ إلا بالعكس, it might make the infection worse, although unlikely. لكن if the medication is working, she will be cleared by now. She's taking the medication for the last 3 weeks every hour. And I agree that I will reculture. طيب, let's say that you did reculture and the smear and the culture is negative. What you would do? You can hand the mic to someone else if you want. Huh?
PCR.
PCR. Of course, each time you do culture, if you have PCR available in your hospital, you have to send for PCR. Huh? You have to. The PCR is negative. Huh? Biopsy. So, you know, sometimes when I speak with junior fellows or sometimes they get nervous when dealing with corneal ulcer. You know, you have the basic skills and the knowledge. So any corneal ulcer should be the same in terms of management, although the clinical features is different, the behavior is different, etc. But you know, if you have the basic knowledge, you can deal with it. Huh? So I will do culture, PCR, confocal microscopy, take photos, monitor the patient. Then no response, you go to biopsy. If the condition, if the let's say the biopsy is negative, and the eye is getting worse, more thinning, impending perforation, you will go for surgery. So يعني the basic knowledge in dealing with with microbial keratitis is the same. Is the same. Although the clinical features is different and the behavior is different, but still it's the same. So I would do biopsy. But nothing strike you here, Ibrahim? By the way, the biopsy is negative. And the clinical feature is the same. She's not improving nor worsening.
The eye is not severely inflamed.
The eye is not severely inflamed. Okay. Anything else you see in this picture?
The edge.
We sent for. I forget to mention. She's taking fortified antibiotic, voriconazole, and PO antiviral. The sensation is intact. Actually, she has a bit of pain. She can't sleep at night.
No pain?
No, she has pain.
The edge of the epithelial defect seems to be rolled.
If you look at 12 o'clock, and طبعا I don't blame you. We had the pleasure to examine the patient in the slit lamp and their magnification with dim light. If you look at 12 o'clock, there is like a line of infiltrate, which resemble perineuritis, radial perineuritis. And when we did the confocal microscopy, we saw the cyst. And Allah يذكره بالخير, Dr. Abdulrahman Abu Ainin, if anyone remember him, he was able to get the medication for us, and we started the patient on chlorhexidine, and she cleared nicely within 4 weeks. And like 1 year later, we did a corneal transplant. And I saw her maybe 2 or 3 months ago. She's doing excellent. We removed the silicone oil, and she's doing fantastic. So this is a monocular patient that was managed properly by applying your knowledge in diagnosing and etc. طيب, then we have the MUTT2 study. Anyone heard about the MUTT2 study? The MUTT2 study, they said, okay, now we know that the netamycin is either superior or equally effective, like voriconazole. How about if we add PO systemic voriconazole? Is this will have any benefit to the patient? And they had almost like 200 microbial fungal keratitis with severe infiltrate. So the vision was worse than 2400, worse than 2400. And patient received topical netamycin and topical voriconazole plus PO voriconazole. They gave 400 milligram BID for the first day. Then for 20 days, they gave 200 milligram PID. So total of 3 weeks. And in the conclusion, there was no any additive benefit to the PO steroid. In the contrary, patient had more side effects from the voriconazole. Okay, so now I'm gonna another case. So this patient came in complaining of decreased vision in the left eye because of corneal edema. He is known case of diabetes and hypertension, and cell sept because of renal transplant. We saw the patient, I think, in 2020 or so, and we elected to do a DSEC for this patient, given his medical condition, difficulty in lying flat, difficulty in sitting in the slit lamp. He's obese, in a wheelchair. So you need to be smart. Huh? So you need to be excellent and you need to be smart. We know that DMEC require more care than DSEC. You need sometimes the rebubbling rate in DMEC is higher than DSEC. So if you have a sick patient that barely can sit in the slit lamp, maybe it's not wise to do a DMEC for him. So maybe he will be better off doing DSEC rather than DMEC. Also, this patient has a bit of corneal scar, and you will see during the surgery, we had to use the indirect illumination. So the advantages of these, or one of the advantages of DMEC, that they will have better vision or 20/20 vision. But this patient, he will never get 20/20 vision because he has corneal scar. So you need to be smart in choosing the proper surgery for this patient. Don't get me wrong, we do DMEC, we like DMEC, but you need to select your patient. It's not about your ego, it's about what's beneficial to the patient. So the patient underwent, this is my technique in doing DSEC. I use the lens glide, and I am proud lens glide user. The advantage of using the lens glide is like a platform or a red carpet that will welcome your graft, and it will prevent the iris from prolapsing or the IOL from prolapsing through the wound. The other advantage, once you inserted the graft, it will be completely unfolded and centered. So you don't have to fight with your graft to unfold it, etc. So the patient did very well, and the cornea is clearing up nicely. He's extremely happy. The عيلك, family member are happy. After 1 week, you received a call from the lab saying that there is a heavy growth of Candida albicans in the rim. Okay, so how would you approach? What you would do? Is this will change your management? Any fellow in the room? Khalid. So you did the nice DSEC. The patient is extremely happy. The cornea is clearing up. No rebubbling needed. Corneal, the epithelium healed completely.
I will make sure to follow up the patient closely. I will assess for any sign of infection to examine the patient again.
Would you stop steroid?
if there is no sign of infection, I may taper down the steroid, but I may not stop it.
Would you give antifungal agents?
I may give antifungal agents like a topical amphotericin to cover the candida.
Anyone agrees with Khalid? طبعا يعني I like Khalid very much. He's one of the يعني smartest fellow that I ever had. Huh? But anyone agreed with Khalid? طبعا giving topical now you placed an inticule way back in the cornea,
Yes.
and the epithelium healed now. So the topical medication, although I know يعني your rationale in giving topical medication, but you know that the amount of antifungal that will reach the graft lenticule is very low.
Yes.
You have an intact epithelium, and we know that drug penetration is not the greatest, to say the least. So I will tell you what we did, but this is by the way the patient's candida or the RIM candida. So we took a picture from our lab. So heavy growth candida albicans. We came across this. I did present this article before, but I really like it, and that's why I decided to present it again to you guys, because personally I learned a lot. So they looked at the RIM culture in patients who underwent corneal transplant, and they had almost around 8,000 corneas, and around 10% had positive RIM. Only 12 of this 8,000 had infection. So only 12 of this 8,000 surgeries had infection. And if you break down the infection, 9 had fungal infection and 3 had bacterial infection. So out of 8,000 surgeries, 12 had infection, 9 fungus, and 3 bacterial. If you look at the bacterial cases that had, or if you look at the cases that had bacterial infection, all had negative RIM. So the RIM culture were negative. And you would expect this to be the case. Why? Because we do have antibiotics in the corneal tissue, in the optisol. So most likely it will take care of the infection. So, or will take care of the bacteria and prevent contamination of the donor to the patient. So most likely the infection or the bacteria came from something else, either during surgery or post-op, but not from the graft. And when you look at the fungal cases, all had positive RIM. Not only that, the positive RIM showed same organism like the patient infection. And this tells you that the patient got the infection from the graft. And this also give the idea of using antifungal agent in the optisol as well. And there is some studies looking at the effect of voriconazole on endothelial cells in the cornea itself. So if you look at the whole cases who had positive RIM, if you did the surgery and you received the call saying, Dr. Khalid, the RIM is positive for culture, regardless bacterial or fungus, the risk that your patient who's sitting in the floor will develop infection is almost 1.5%. However, if they tell you that the culture positive for fungi, the predicted value that this patient will have an infection is 10%. So each time you receive a call that there is positive fungal infection in the RIM, the chances that this patient will develop an infection is 10%. So what we did to our patient, we gave the patient voriconazole, 200 milligram BID for 10 days. And to be honest, we gave him this to treat ourselves rather than to treat the infection. Because all the 9 patients who had interface infection or infection from the graft, especially if it is a lamellar surgery, they will need therapeutic keratoplasty. And this will take us to the second case. So this patient had in our hospital a DSEC, then she uncomplicated DSEC, then she disappeared for 3 months, and she came in complaining of pain, discharge, redness, and decreased vision. من يبي ياخذ الكيس هذه؟ Anyone? إبراهيم، من زملائك إبراهيم؟ ها؟ You want to do it? Okay. Okay.
I can see a slit lamp photo showing an injected eye with the central corneal ulcer with the infiltrate with the nasal side. I can see sutures which are not loose or exposed. I can see to the temporal side, I can see areas of new vascularization of the cornea. I need to assess the anterior chamber and also the fundus as well. Okay, there is good depth, but I cannot assure myself about the AC quietness.
Okay. So, يعني what is in your mind? Where is the infection?
It is transmural, passing the whole cornea, reaching to the endothelium as well.
To the endothelium or
no, the interface between the
interface,
the interface. Yes.
and if you would describe it, how would you describe it?
Placoid.
يا سلام عليك. Yeah, it's a plaque-like infection, huh? This plaque-like infection, يعني usually you see it with what organism?
Fungal.
Yeah,
infections.
but what fungal?
Fusarium, Candida.
With Candida.
Yes.
With a plaque-like infection, usually you see it with Candida. ها؟ لو انك قايل Candida، انت الحين فلو ظاهر صح؟
No. R4.
R4 كان بقول لك اذا جيتك انا as an examiner بعطيك 10 درجات زياده. بس تستاهلها.
الله يعزك.
طيب اصلا عجبتني يوم قلت plaque-like. So this is infection that extend all the way to the epithelium, which tells you that it's been going on for a while, huh? And heavy infiltrate in the interface. Can you يعني differentiate where is the graft, where is the lenticule, where is the patient's cornea?
I believe it is anterior to the graft, the area of infiltrate.
This is the plaque-like.
Yes.
This is
The graft. Yes.
How would you manage this patient?
The penetration is not that much for this case, but I would start amphotericin B topically, and also I would add oral
So
voriconazole.
of course you will do culture, and the culture came back positive for Candida. Then you will give the patient amphotericin B.
B topical Q1 hour
Okay.
around the clock with oral voriconazole because it's deep in this case. Rule out also.
What should we do before giving patient PO voriconazole? Huh?
Renal function test, hepatic test.
Huh?
Renal function test, hepatic test.
Renal or hepatic or liver?
Both.
LFTs. Because it can cause hepatitis.
Yes.
It can cause hepatitis. طيب. Do you think the patient will improve in your therapy?
Given the pathogen, yes.
Oh, you will be surprised that when you have infection sequestered in an interface, people tried everything. Tried giving topical medication, giving systemic medication, injecting voriconazole in the stroma, injecting antibiotic in the interface. Not only that, going to the surgery, removing the lenticule, doing AC washout and putting
Intrastral.
and intracameral all fail. Usually when you have an interface infection with fungal infection, most likely patient will need therapeutic keratoplasty. And the patient underwent therapeutic keratoplasty. طيب, I think I'm gonna stop here. Any question? Yeah, did you absorb some of the material?
The whole. Thank you.
طيب.
Thank you, Dr.
الله يعطيكم العافية.